Okay. All right. So they said to just prepare a couple of short slides and just to give an overview of IMMY, and a lot of you in here and probably know us and our history and have worked together. But just most of you know this, like I said, but our focus has been on fungal diagnostics for over 40 years, and really trying to bring those diagnostics down closer to the patient, and really trying to deliver that to where we have tools available to where we can get a quick diagnosis, a fast diagnosis, as we've heard in some previous presentations, where that is an important piece of everything, where you can get a quick diagnosis to where you can take the next steps appropriately. And so that's been our focus, is trying to do that, not just at the bigger reference lab level, but all the way down to the smallest clinic in the most remote parts of the world, really. As you can see, we've delivered these diagnostic tools to over 75 countries throughout the world, and have worked with many of you on projects in those different countries. The tools that we have available range from LFAs to ELISAs and latex agglutination, and then some older technologies like immunodiffusion and complement fixation. But just to roll through those pretty quick, the LFAs we have available, as many of you have run or are running, our CRAG LFA, the copper antigen. And then we have an Aspergillus galactomannan LFA that has recently been put on the market. It is available through CE, and we are currently working through our FDA approval with that, and awaiting that response. We also have a coccidioides antibody LFA, which I think was presented on a little bit of data earlier in the day. ELISAs, we obviously have those for cocci, for histo, for crypto and blasto. And then you can see that the latex agglutination kits that we have available is there as well, crypto, histo, cocci, and sporo. So that's really been, like I said, our focus is just trying to bring those diagnostics down closer to the patient, and get these more rapid, close to point of care as possible for these fungal infections. So that's very quick who we are, the little 5-minute spiel that we needed to give, and then I'd love to answer any questions as best I can.
So thank you so much, JP. So I neglected to introduce myself, so I apologize for that. So for those who don't know me, my name is Lfas Schwartz. I'm an infectious disease physician at the University of Alberta in Edmonton, Canada. So thank you again, JT, for that nice overview, and thank you for entering the space that other diagnostic companies have really neglected, and of course among physicians that have come to this webinar, who are all familiar with the major gaps in both the diagnosis and management of fungal disease. It's really important that we have a company like IMMY that's really come to the table to hear our concerns and to try to address some of these. So in that vein, maybe we can start, if anybody has any questions for JT about the work that IMMY is doing. And if not, then we can open more broadly to sort of a roundtable discussion. If anybody has any questions, they can maybe put their hand up, or can just go ahead. So maybe I'll pose the first question. I mean, we had some wonderful overviews today in terms of all the different kind of emerging facets of diagnostics, and one area that really stood out as an exciting area of growth is in Dr. Fernandez's talk about how LFAs are transforming mycology. And we heard a lot of great talks about kind of the future of mycologic diagnostics, running the gamut from breath biopsies to PCR, but LFA is already changing care. We're all familiar with the cryptococcal antigen LFA. Are there any plans from IMMY to further develop their portfolio, particularly within LFAs?
Yes, definitely. As far as like specifics, I can't really go into exactly what we're looking at, but definitely our hope is that we can add some of these different infections and have a tool that is more rapid, like our cryptococcal antigen, like our aspergillus, and bring the technology down to where it is something that can be run in any clinic, on any shift, and where it can be affordable and accessible, like we've tried to do in the past. So yes, to answer it broadly, we are looking at a few various options for new tests that are on that platform as well.
Okay, maybe I'll open it more broadly to the group. We've got so many experts here really running the gamut. And so I'm sure IMMY would like to know, but certainly I'm curious. We have a lot of translational scientists as well, trying to identify what are the biggest research gaps or what are the biggest clinical gaps in terms of diagnostic tests for development. So maybe if I can pick on Neil. Do you want to start us off?
Yeah, so I'd say Candida. I mean, just look at the number of fungal infections, right? And candidiasis causes diverse diseases across various patient populations. And, one thing I always try to teach the fellows, when I was a fellow, 80% of aspergillosis patients died, and 30 to 40% of candidiasis patients died. And now our mortality rates in high-risk cohorts are probably more like 25% with aspergillosis, and they're still 30 to 40% with candidiasis, maybe marginally better with the echinocandins. And the big difference is, the aspergillus community took imperfect tests and put them into treatment algorithms. And the Candida community has not done that. So what's limiting the Candida field really has been, on the one hand, failure to develop and employ these algorithms. But secondly, the cumbersomeness of tests that are out there. Beta-glucan, which perhaps could be something of a galactomannan equivalent, is cumbersome. People send it out. It takes forever to get done. There isn't a standardized PCR assay. T2 Candida is a self-contained system that only detects Candida and is expensive. So, we really need something. A lateral flow here, if it were cheap enough, if you could do it in ICU at bedside, would be potentially transformative. And with that, let's get the studies done and try to do it. So I'll make the Candida pitch, but it's something of an embarrassment that the Candida field has not moved more in the past 30 to 40 years, quite frankly.
And Neil, I just want to compliment you on the excellent talk that you gave, and I particularly liked how clearly you outlined the considerations in terms of not just the operating characteristics of a test, but the pretest probability in going to inform your decision on whether to pull the trigger to treat. But you obviously kind of went through the way that you think through these problems, including these fairly complex mathematical equations. And ideally, if we had better tests that had better operating characteristics, of course you always need to consider your patient, but I feel like we end up doing these complicated gymnastics in order to be able to ascertain whether somebody may have the disease or not, in part because the tests that we have are so imperfect.
Yeah, I would just say though, Elin, you don't need to do the math. I mean, if you've got a test that performs like a beta-glucan, and you use it in some setting, perhaps a bit higher likelihood than all sepsis comers in the ICU for 72 hours, you can probably get utility out of that. And I would say, look, The hem-onc patients are complicated. No one does this math, but they know that if they use a galactomannan in this setting, the math works, they trust it, they know there's going to be some degree of false positivity, but as a community, they've decided, it's still worth implementing. Yeah, that said, if we could get above 60 to 70% sensitivity, and 80 to 90% specificity and get more to like 80, 90 in a real world test, I think that would really move the candidate field forward, because I think the sensitivity and specificity for what we have right now are just low enough to make it complicated enough that widespread adoption of these has not really followed. So that's all you need to do, JT. Get us, an 80% sensitive, 90% specific candidate assay for bedside use, and you can count the money.
Thank you. Thanks for that insight. Yes.
I just want to add, I agree that we'll be working with imperfect tests, and I completely agree with Neil that you don't really need to do the math on this. You can sort of identify a cohort of patients that are going to be pre-test probability between 10 and say 30% for invasive candidal disease. And so, if you get a positive biomarker in those, the probability is going to be greater than 50%, or as Neil said in his presentation, greater than 30% is sufficient. And then in that situation, you would treat. And I think, what frustrates me from a lab perspective is that, quite often these patients who have these risks, these pre-test probability of disease, is that the clinicians are quite happy to initiate empirical antifungal therapy. Yet when we get a positive result, there's this doubt, is it significant or not? And you're thinking, well, okay, it might be incorrect. It might be a false positive result. But would you have initiated empirical antifungal therapy anyway? And so now you're in a situation that you've got more evidence that the patient does have fungal disease. So surely that's got to be an increase in confidence that what you're doing in terms of starting antifungal therapy is worthwhile. And I think my other aspect in terms of diagnostic testing is when we're working with imperfect tests, is it's a change in mindset in a way that microbiology has always provided if it's positive, the patient possibly or probably has this infection. Whereas sort of classical microbiology, where negative can't really be used to exclude disease. And so it's changing the mindset that, with a lot of these tests, and because of the pre-test probability or low incidence of fungal disease, that when they're negative, we do have the confidence to exclude disease. But I also think from a diagnostic perspective, we need to be looking at, you can have a range of performance where you've got combined sensitivity and combined specificity coming in. So specificity and sensitivity combined coming in and say 160. So you've got 80% sensitivity and 80% specificity. But I actually would rather have a test where one of the parameters is approaching 100%, so either sensitivity or specificity. So subsequently, you can really exclude, or you can confirm disease depending on which parameter is approaching that 100%. And arguably, when you end up with a test on paper where both of them sort of both sensitivity and specificity around that 80% mark, it sounds great, but in the real world, it's very difficult to interpret.
Even at night. Sorry, Neil. Go ahead.
I was just going to say, Elin. I mean, as you all know, right? What we constantly teach is you shouldn't be ordering the test if you don't know what you're going to do with the results. So if you're not going to use a positive result to guide therapy, then don't order it. Just do what you're going to do. So that's sort of the common mistake. And what happens, particularly like in the candidiasis world, is because people haven't thought about why they're ordering the test. They get a result, they don't know what to do with it. And then this feeds this perception, oh, the tests suck. We don't know what to do with it. So if you're using the tests rationally and trying to optimize their use, then at least you have some sort of notion of what the real strengths and limitations of it are. When you have no idea why the hell you're ordering it or what you're going to do with it, and then you get it and you don't know what to do, that's not the test, that's you.
I think a good illustration of that, of what you're saying, Lewis, about you really want a good either sensitivity or specificity, and on paper, even something like 90% sounds good. You talked about PJP PCR with specificity of 90%, and that sounds great. But when it's being tested on the the patients that I see these results come back on, none of them have, clinical syndromes or, host characteristics consistent with PJP. And so that, even with 90% specificity, most of them are still false positives. So
it's interesting, and I think sometimes that's where the qPCR and the burden is important. Having an idea how strong that positive result is, and generally that's what we would work with. But going to what you're saying there, I get a low level positive in a patient that the test has been requested. So you're thinking, well, why have you requested it if you haven't got a clinical suspicion of PCP? And I would then say, okay, give me a glucan as well. Or, if it's an upper respiratory tract specimen, send me a lower respiratory tract specimen if possible. And I think it's that combination of testing, combination of positivity that increases your confidence. And in a situation where you've got a low level sort of PCP positive on a BAL and a glucan is negative, and as you said, the clinical picture isn't typical of PCP, then I'm thinking, okay, yeah, that's a false positive result.
I think this all kind of comes back to one of the points that Neil made in his talk about the importance of having stewardship of antifungal, fungal diagnostics, and even antifungal stewardship is a very nascent field, and most academic centers don't have the capacity to be able to provide that. Diagnostic stewardship is really like kind of a whole other planet that we haven't gotten to, but it's so important because it leads to misuse of antifungals and and additional unnecessary tests and so on and so forth.
No, you're spot on. Sorry, I was just going to give an example across the COVID pandemic. Wales is a country of 3.5–4 million people, and we have 8–9 microbiology labs. But I had to take control of the positive results going up just across that area, a very small area in comparison to North America. And so it makes it very, very, the logistics of doing something like that are very, very difficult over such a large, geographical area.
And, the fact of the matter is that these sorts of services are not remunerated. And so we need to be making pitches to, our payers, whether, that's your hospital system in the US or, in Canada, we have provincial centralized payers, but to make a pitch why this is cost saving and ultimately of value. I just want to give some people who have entered some questions or comments into the chat an opportunity to ask their questions. Dr. Samatar, would you like to ask a question to JT?
Hi, Ilan. Can you hear me?
Yes, we can.
Yeah, a very good morning. I just want to ask that IMMY, whatever the diagnostic test they have for this histoplasma and also for aspergillus, it is based on the galactomannan assay. Now, we have seen that in post-TB patients, there is a high prevalence of this chronic pulmonary aspergillosis. And here in India, we don't have any diagnostic kits or assays which are available for the diagnosis. Like we don't have any rapid kits for this aspergillus IgG/IgM. It is available with other companies, but they are not in India as of now. And also for histoplasma galactomannan testing, we have this ELISA-based platform, and we don't have a urine antigen detection, which is associated with a very high sensitivity and also specificity. So does IMMY have any plan in the near future to come up with this sort of kits? So that's my question.
Yeah, thank you for asking that. For Aspergillus IgG/IgM, that is something that we had looked at in the past, and with some other projects that had come on our plate, we had tabled that for a little bit. It wasn't necessarily, didn't tell you specifically IgG or IgM, it was more of a total antibody, but we haven't really done much work with that recently. Obviously, we're very interested in histo, urine, and the different platforms. Obviously, we have the ELISA currently, which is, we understand, we're fully aware that logistically, getting that around the world is for any type of ELISA is somewhat of a challenge just for transport and storage and all of that. So it's on our radar. Again, I can't talk about specifics about timeframes and all that, but it's definitely something that we're interested in and looking at.
Now, Dr. Nucci has made a comment about the problem with Canada is the heterogeneity of the host. And I guess one of the areas of, one of the realms of diagnostics that we didn't really cover in today's session, but we have discussed at previous MSG webinars is host metabolomics as part of kind of a future avenue of diagnostics, not quite ready for prime time yet. Did you want to speak on that at all, Dr. Nucci? Maybe Neil, as that comment seemed to resonate to you, maybe you can just elaborate on that a bit.
Yeah, no, I think the point is absolutely spot on. The heterogeneity of disease and heterogeneity of host. So I think you've got to start by asking yourself, who is my host? Who is my patient? With candidiasis, then what type of disease are they at risk for, and how big is that risk? But the approach is wholly different. To me, the big bifurcation points up front are kind of surgical ICU versus medical ICU, and that broadly kind of correlates with candidemia risk versus intra-abdominal or other deep-seated candidiasis risk. At some point, you're going to have to accept that you're just not going to capture everyone at risk for candidiasis with a stratification strategy. So if you look at Luis's approach with the MSG criteria, you can get to 10%, 15% likelihood, but with that, you are going to miss some patients. There are going to be 0.5% of patients on the floor with a fever who actually have candidemia. So again, I think trying to capture everything, trying to be perfect in a way is the enemy of being good enough. I think if we focus on the very best defined groups and introduce candidate testing in those rather narrow settings, we can make some dent, and there are, other patients who are just not going to be able to reach with our current testing.
Elan, just to touch on sort of the metabolomics and proteomics and transcriptomics, the heterogeneity we see in the Candida, I still think is going to lead to sort of some not confusing results, but conflicting results between patients, even when you go down these sort of novel approaches. And I'm basing that on some work we did with colleagues in Würzburg, where we looked at patients with aspergillosis post-COVID and aspergillosis in hematology. And we looked at cytokine responses, and we found that IL-8 and caspase-3 were high in the hematology patients, were actually indicators of invasive aspergillosis in the hematology setting. Whereas in the patients with kappa, we found that they were really low, and they were probably risk factors for developing aspergillosis. And so you've got two different populations, the ICU patient with aspergillosis, and then you've got the hematology classical sort of, underlying host factors why they've got aspergillosis, and you've got different cytokine response, one being a marker of disease and the other being a risk factor. And I think that equally applies to the Candida patient where the heterogeneity, I'm not saying it can't be done, but I think there's a lot of work to be done so we gain an understanding of how the cytokines and the chemokines respond in different patient populations.
I think one thing about it, Lewis, I don't even think it needs to be that sort of complicated with sort of host immune profiling. But the reason aspergillosis testing and interventions worked is your highest risk cohort, your bone marrow transplants, your heme malignancies back in the day, 15 to 20% of those patients would develop invasive aspergillosis. So that's a high enough likelihood that you can start plugging in these type of diagnostic tests, particularly since then you're going to look at symptoms and radiographic findings. You kind of put it all together. So in a way, those populations at risk for invasive mold infections, at least in the highest risk cohorts, are just more likely to have disease than you can get anywhere with at least candidemia. In the candidiasis world, maybe the complex abdominal surgeries with intra-abdominal candidiasis, you start getting to 20, 30% likelihoods. But that's been the biggest difference. There was enough of aspergillosis in the highest risk, well-defined cohorts where you had medical oncologists sort of driving use that you were able to really come up with these paradigms for intervention over the past 30 years.
So we just got a warning from the industry headquarters that this is going to close in about a minute or so. I just want to ask Lewis, do you think that we are any closer to having a better grasp on which COVID patients developed kappa?
No. I think it's yeah. I think we are just gaining an understanding, and obviously there's a lot of clinical risk from the steroids, from the monoclonals.
It looks like the ones in Europe.
It's very difficult. I don't think we will. I think we'll probably be at the situation that it's finished. Well, hopefully the pandemic's finished, and we might retrospectively gain the data.
But it's a model for thinking about flu-associated aspergillosis, where many of the same issues sort of play.
Definitely.
Yeah, and it's such a dynamic landscape, as you know, with different immune modulatory therapies that are in use. The presence of vaccination, etc. So I just want to thank everybody for participating, and we'll see you in the